Good morning. My name is Michael Bourke from Westmead Hospital in Sydney and the University of Sydney, and I had the pleasure of talking to you about our recently accepted paper in gastrointestinal endoscopy entitled Long-Term Outcomes After Endoscopic Submucosal Dissection for Relative Indication Early Gastric Cancer in Non-Surgical Candidates. So the Japanese Gastric Cancer Association published their 2018 guideline in the Journal of Gastric Cancer in 2021. And absolute indication gastric cancer is a smaller tumor, generally absent ulceration, well-differentiated superficial submucosal invasion, i.e. less than 500 microns, absence of lymphovascular invasion or poor differentiation. We know that ESD is a highly effective treatment for treating early gastric cancer. There are a myriad of publications from Japan, Korea, and Southeast Asia demonstrating all of this. But there are far fewer publications from the West, and ESD has been slow to gain traction because the easiest target lesion to train on early gastric cancer is relatively infrequent. In fact, in a large Australian study, the prevalence of early gastric cancer was only 40 cases per 5 million population per annum in an ethnically diverse state such as Victoria. This accounts for about 20% of all gastric cancer. In the West, these patients tend to be older and more comorbid, so surgical options are not so attractive, although in the West, gastric cancer has generally been a surgery-centric disease. We sought to evaluate, we previously published on great outcomes for absolute indication disease in GIE a couple of years ago, and we sought to evaluate the outcomes for relative indication patients. These are patients with larger lesions, plus or minus surface ulceration, poor differentiation, lymphovascular invasion, R1 excision, and so forth, with deep submucosal invasion greater than 500 microns. So these are patients that, if they were surgically fit, they would generally be managed by surgery. However, many of these patients are elderly and comorbid and are not suitable for surgery. Then they fall under the umbrella of relative indication ESD. The beauty of the ESD is that it provides definitive T staging, but then can also provide the risk of lymph node metastasis and prognostication about what are the risks to the patient and make an informed decision about how the patient should be managed, much more so than just guessing based on the histology, CT scan, cross-sectional imaging, etc. So we look back over the 10-year period up until November 2022 at our gastric ESD experience for early gastric cancer. There are 157 lesions resected in 149 patients. Of these, 109 tumors were absolute indication cases, and 48 were relative indication cases. Across the entire cohort, this was an elderly and comorbid cohort, age of 73, and Charlson comorbidity index of 4.2, mean index of 4.2, which means these are not healthy patients. When we compared the two cohorts, en-bloc resection was 96% versus 88% for absolute versus relative. R0 excision, 94 versus 63%. Median follow-up was 52 months, or nearly 4.5 years. 5-year, excuse me, overall survival was not significantly different between the two groups, 89 versus 78%. And disease-free survival, again, 83 versus 75%. So in this elderly comorbid cohort, ESD provided luminal control of the disease without conferring any significant risk to the patient. Indeed, there were 8 episodes of post-procedural bleeding, or nearly 5%, all managed conservatively. There were 4 intraprocedural perforations, all recognized intraprocedurally and closed. There was no need for surgery from any adverse events related to ESD. So it was indeed very safe. So in conclusion, we're able to demonstrate that ESD for relative indication early gastric cancer in an elderly and comorbid population was indeed very safe. No surgery, no mortality, no significant morbidity attributed to the ESD. Admittedly, a very experienced centre, and outcomes no different than absolute indication patients, despite there being much more advanced histology, including, for example, the relative indication versus absolute indication. Ulceration was 13 versus 54%. So absolute indication ulceration was only 13% versus 54. Submucosal invasive cancer was 15 versus 73%. Poor differentiation was 2% versus 38%. LVI, 4% versus 40%. And SM2, 5% versus 50%. So these were advanced lesions that could be excised generally en bloc and generally R0 by ESD, conferring long-term disease-free survival and overall survival for this elderly and comorbid cohort. So hopefully we'll see more data like this from the West because there's a great potential to help these patients. When you see an advanced lesion in a patient who's not surgically fit, then there's a great opportunity to refer this case to an expert centre and have this lesion be considered for en bloc excision by ESD. Thank you for listening.